While Dr. Type gets his presentation set up, I just wanted to do a little introduction. First of all, Dr. Brian Type is one of the most foremost experts on lung disease. He serves as the Director of Pulmonary Rehabilitation Program and Smoking Cessation Programs at the City of Hope. He is Medical Director of the Respiratory Disease Management Institute, now called Pulmonary Rehab for Life, in Pomona and Monrovia, California. As an inventor, he has received multiple patents for devices to serve patients with lung disorders, specifically designed patents for oxygen therapy and oxygen conserving devices and high-flow oxygen systems. He received his medical degree from the Herrick Medical College in Nashville, Tennessee. After medical college, Dr. Type served as an Army flight surgeon during the Vietnam War era, prior to his pulmonary fellowship in 1972 to 74 at City of Hope, where I had the honor of first meeting Dr. Type as a young respiratory therapy student learning how to do blow, blow, blow. Okay? 20 years later, our paths crossed again, as we were fortunate in Florida to partner on educational and clinical projects and establish a long friendship. We, as the Breathe Strong team, are honored to sponsor and support the first speaker this morning as we honor Dr. Thomas Petty and his legacy. I am thankful to call Brian my friend and mentor. It is my honor to welcome and introduce to you a friend of the pulmonary community, Dr. Brian L. Type.
I would actually start with a little story. And the story is about a patient of mine. Her name is Mary. I won't give her your last name, HIPAA requirements, although Mary was about 80 years old back 40 years ago. But she was a writer and a poet, and she had very severe COPD. She would come to a clinic visits, and she would always write a little story for me, or a poem. And one day she came in. She didn't look quite as well put together, and she said, I don't have anything written for you. I said, well, don't feel you have to, but what happened? She said, well, I was tired last night. I went to bed so that I can get up early in the morning and write something for you. I said, well, what happened? She said, I was wakened last night with an obscene telephone call. I said, you were wakened with my obscene telephone call? She said, yeah. Actually, it was kind of interesting. First, I didn't put the telephone beside my bed. It was in the kitchen. I said, oh my gosh. She said, yeah, when the telephone call came, it was after 2:30 in the morning, and so I thought it was an emergency, so I ran to answer the phone. I said, you ran to answer the phone? She was barely short of breath on any kind of movement, even talking. And yeah, she said, yeah, I got to the phone. I was really out of breath. And the guy on the other end of the line was going, and I was going, and he was going, and then finally he said, who's making this call, you or me? And that is a true story. And that's a story she told me that particular day. Okay, so I titled this lecture, Enjoying Life with COPD. And one reason I titled the lecture that was because this was Tom Petty's mantra. You can enjoy life even if you have COPD, even if you have pulmonary fibrosis, even if you have asthma. So let's talk just a little bit about Tom Petty. He was an amazing guy. He was a phenomenon. There's nobody that I can think of in any field who was like him, that actually ran the field himself. He had over 800 articles, and some of them introduced new concepts. He led the field. He directed the field. He did research. He directed the research in the patient care part of the field. He popularized pulmonary medicine. You'd hear Tom talk, and you say, yeah, I love pulmonary medicine. You know, and I think I can do a lot of good things for people who can't breathe. I think somebody from the Lung Association said, when you can't breathe, nothing else matters. And that's really true. He was the engine that drove the field, and he had a myriad of contributions. Now, he also played the violin. A lot of people didn't know that, but he played the violin in high school, and he was the concertmaster of his high school orchestra. When my daughter, who is now 40 years old, she was 5 years old, she met Tom Petty for the first time, and she played for him. And over the years, she played for him, including some of the conferences, one of the conferences that was held here in 2005. Tom's impact, count up the number of people who have asthma, COPD, pulmonary fibrosis, adult respiratory distress syndrome, something that was discovered by Tom and his group, lung cancer. Over 50 million people today and in previous days are all benefiting from his ideas, his insights, and his direction. So here was the first article on ARDS. We didn't know about this before this article came around. He was the president of a foundation, which I'm one of the people in that foundation still. It's a Pulmonary Education Research Foundation. And he wrote regular letters from Tom, insights about living, about life, about not only lung disease, but how you approach life. And this is a graph of his articles. I want everybody to memorize that. Right? He wrote this book with Rich Cassaberry, who is now president of that same foundation. And it was the main book, the first really big book on pulmonary rehabilitation, or at least one of the first books. Tom Petty was involved with the other first book as well. Liquid oxygen. Liquid oxygen was not a thing until Tom came along. And then he showed in ways that you don't have for almost any other disease process why oxygen actually is not only helpful in making people's lives better, but also making people's lives longer. And so he was really the main force behind two studies published in 1980. I remember when those studies came out. I was just a little kid at the time. Anyway, Tom's impact was on pulmonary rehabilitation. Anybody here of pulmonary rehab? Okay. Yes, there we go. And oxygen therapy, cancer. The relationship between cancer and COPD, there seems to be a relationship. It's not well worked out, but we do know that people with COPD are more likely to have lung cancer than other people who smoked. Limits of oxygen therapy. You give a person 2 liters per minute, they have saturated 95%. Well, 2 liters per minute? Why don't we give them 3 liters per minute? They'll do even better. That's not true. Even oxygen has its downside. And he showed that in one of his studies. Patient participation in their own care. That's a key. And that's kind of what we do. It's what the patient does at home that makes all the difference in the world. And then finally, humor for the health of it. And Tom did this for patient support groups. And of course, he enjoyed life as well. He enjoyed his patients, he enjoyed his colleagues, and we all enjoyed him. Okay, now, let's get to the lung. Okay, so we will look at the lungs, and we'll see something about the workings of the lung and what could possibly go wrong. And then we'll look at ways that possibly we can help, and some mechanisms by which this works. So it makes sense to you when you're trying it. Let's see if I can get that arrow there. Okay, so I do animation, and I guess I get a little bit corny at times with it. And this is a very expensive animation because I filmed it on location. Those of you who don't know, I guess everybody knows, that's the Mars background. Okay, so you know that the heart and the lungs are intimately connected, and they're all a part of the same thing. The lungs have about 500 million alveoli. 500 million alveoli crowded into that chest. If you don't believe me, you can count them yourself. Want to start? Okay. And then you have multiple tubes, bronchial passages leading to those alveoli, and there are about 23 branchings. And when you get past the 16th branch, the way of transporting is a little bit different. I'll show you that too. So, of course, When you breathe in oxygen, of course, these are very large oxygen molecules, they go into all the different branches, but you get past the 16th branch, there's very little movement of air in and out. So those alveoli are filled with air. What's going on? Well, it's by molecular diffusion. Okay? So if somebody from that table opens up a bottle of perfume, within seconds, I'll smell that perfume. Why? Because of movement of molecules. And that's part of how our lungs work. If you know that, then you might think, well, I wonder why pursed lip breathing works. Maybe this helps us to understand that. Okay, so here I get, of course, this is just diagrammatic. It's not exactly the way the lungs work, but as you get into the very advanced section of the lung, these are all molecules working and moving around spontaneously. But they move around spontaneously enough, and there are enough of them, that you get oxygen into the bloodstream and carbon dioxide out of the bloodstream, and finally out to the room air. So here is one alveolus, and of course it doesn't look like that, but this is the diagram of it, and with a blood supply going around that alveolus and picking up oxygen. And when it picks up oxygen, notice that the blood turns red. So to press that point a little bit more, I say, okay, what happens when you give oxygen to a red blood cell or attach oxygen to a red blood cell? Well, it turns red. And notice this is the oxygen saturation. And that's how your oximeters work. There are two wavelengths of light, one for red, one for infrared, and one represents the oxygen, the hemoglobin with oxygen on it, and one represents the hemoglobin without oxygen. And it goes through a set of equations in that little chip, and it gives you a readout of what's your oxygen saturation. Of course, now you've got to circulate the oxygen through the bloodstream. And those of you who don't recognize this is the Arboretum in Los Angeles Arboretum in the background. I borrowed this from the internet. So anyway, you have 30 trillion cells in your body that are constantly in need of oxygen and in need of getting rid of the CO2, which is sort of the waste product of metabolism. And I kind of show that this is, I tried to do this with my arm, and it was just very skinny, and so I borrowed my son-in-law's arm. And so this is his muscle. And so here the blood is circulating in the tissue areas because that's where it's all supposed to go. And it goes from the red blood cells through into the cells. And these little structures are called mitochondria. Okay? We call them mitochondria because that's where all the energy is. Mitochondria. You know, it's bird, it's a plane. No, it's mitochondria. Okay. Okay, so this is the mitochondria. And each cell, each one of your, how many million cells or trillion cells do you have? 30 trillion cells, right. And each one has approximately 1,000 mitochondria. I'm not going to ask you to count those. But here you got food and oxygen, and it creates energy. That's where the flame is. There is somewhat of energy consuming, but it doesn't look like a flame in there. But what comes out is CO2. And so CO2 has to travel again to the lungs where it's expelled to the air. Now, this is what we call a body machinery. And this animation took me a week to do. So it's a 25-second animation, but it describes the lungs. The oxygen goes into the lungs. It's got to go through to the blood supply, goes through the blood supply to the muscle, and CO2 comes out the same way. And right here is an alligator. Bob, one time you were driving around in Florida, and I said, "Aren't there alligators in Florida?" You said, "Yes, there's one right over there." And so I took a picture of the alligator, I put it in the water, and that's a part of the animation as well. But the idea here is the body machinery. What does exercise do for you? What exercise does for you, it not only improves the lungs, or the heart and the blood vessels, but it also improves your ability to utilize oxygen. So here you've got this massive distribution system that we all take for granted, 30 trillion cells. You know, Amazon can't do that well. Think about it. Not even with drones. So this is a huge delivery system, and what exercise does is it helps all of the components of that delivery system, getting oxygen in and carbon dioxide out, and we just all take it for granted. We do it, rats do it, mice do it, right? So, what can go wrong? Well, COPD. This is an old kind of diagram. It's called a Venn diagram, where it's the overlapping of chronic bronchitis, asthma, and emphysema. And so, chronic bronchitis, of course, is the inflammation of the bronchial passages. Asthma, the tightening around the muscles, the muscle tightening around the bronchial passages. And emphysema involves the alveoli. But it involves the alveoli in a way that it becomes an obstructive lung disease as well. Obstructive lung disease means that the biggest problem is getting air in and out of the lungs in a fairly expeditious fashion. And with chronic obstructive pulmonary disease, it's very difficult to move air in and out of the lungs. So what does COPD look like? Well, this would be a normal lung, but right up here, this would be emphysema. Emphysema is basically a lot of holes in the lung. Or another way of looking at it is that you have all those, remember all those alveoli? What happens if the membranes between the alveoli break down? And they break into one another like bubbles, like soap bubbles. And you see a bunch of soap bubbles, and they start to combine, and they become larger and larger and larger soap bubbles. Well, they become larger and larger alveoli that are really not accomplishing anything, and they're taking up space. And that is a part of the problem. Now, what happens is, let's say you've got these airways, and so one component is chronic bronchitis. Chronic bronchitis is the inflammation of those airways, and is production of a lot of secretions. Now, mucus is a good thing, right? It's a protector, and it's a lubricant. But too much of a good thing, like Mae West used to say, too much of a good thing is wonderful. No, it's not. And in this case, too much mucus is not a good thing. Now, here, these are identical panels. But on the right side, I'm going to show how emphysema sort of develops. There's one concept of how they develop. But if you take a look at a cross-section of lung, it doesn't look like a bunch of grapes, like we depict it, right? It looks like a sponge. And all of these are alveoli. And the alveoli are elastic. And they kind of pull or tether open the airways. And so they keep air flowing into the alveoli. Well, what happens in emphysema is instead of tethering open the airways, these walls break down. And when they break down, they're not holding the airways open. So those airways tend to collapse. And when those airways collapse, then you're not getting air in and out. And so it's obstruction. Now, here is another concept. We call it pendiloop. Anybody want to write it down? Okay. Anyway, what happens here is that here's the emphysemic portion of the lung, and here's the more normal portion of the lung. And notice that as you're breathing, the emphysema portion of the lung sort of trails the more normal portion of the lung. So not only is the air moving in and out of the lung, but it's moving back and forth between these alveoli, between the good ones and the bad ones. And that's bad for getting oxygen in, and that's bad for getting CO2 out. But that is a part of what is going on if you have emphysema. Now, what happens is that if you do pursed lip breathing, you get past some of that stuff because you slow down your breathing and you allow sort of the CO2 coming out of both sections of the lungs to gather, and they both come out. So it's one of the reasons why pursed lip breathing might be working. Now, here's a CT scan. I'm sure some of you have seen CT scans, but basically what it is you take this X-ray, and it represents all portions of your chest, maybe your abdomen, so on. Depends on how far the CT scan goes. And then the computer makes it into sections, so you can actually see what each individual section looks like. And it takes the picture like there's a camera in the middle of your body looking upwards. So this is the right side, this is the left side, this is the trachea, this is the heart and a portions of the aorta. You can't see it very well, and you also can't see the spine, but the spine is in this view. So this particular section is about right here, okay? Now, this is an emphysema lung. So you see all these holes. Again, alveoli, they become larger and larger and larger, but not really doing very much in the way of gas exchange. Now, some of you have had spirometry. There's a spirometer out there, and it does what we call a flow volume loop. Now, the flow volume loop looks kind of like this. Okay? So, flow, how fast you can move the air, versus volume. And that would be a typical appearing flow volume loop. So, if somebody would come to me, I'm used to looking at these things, and show me a flow volume loop that looks anything like this, I'd say, that could be a normal flow volume loop. Let's see what the predicted values are for your age, height, and gender. And within this flow volume loop, here is your tidal volume. This is your regular breathing, everyday breathing. And notice you have plenty of room to inhale. But let's say if you have COPD with a large emphysema component, you can't take a deep breath like that. So what you have to do is you have to expand your chest bigger and bigger and bigger. So everybody try this. You take a deep breath. Now a little bit deeper. Now try to do all your breathing at the top of that breath. So, sorry about that. So you're breathing through a lot of stale air. And your lack of ability to continue to take breaths of air because you can't empty your lung in time to get the next breath of air in, you're limited in your, not only in your flow, but you're limited in your volume. And this is kind of what it looks like. So, say a person with COPD, any of you ever get short of breath? No, nobody gets short of breath? Okay. And you get more short of breath, right? And when you try to get up and move around. Well, one of the reasons for that is that I put it on the wrong slide. No, one of the reasons for that is, let's say if you have emphysema at the top of the lung and more normal lung tissue at the bottom of the lung, and at rest, there's enough time to empty your lung for the next breath. But if you're breathing faster like you do when you're active, when you're exercising, then what happens? You don't have time to empty your lung for the next breath. So you start trapping air. You start going up to the... You're stacking air on top of the other, and what happens is you're breathing through a lot of stale air. Some people can identify a little bit with that, okay? But that's what happens. And the emphysema portion of the lung crowds out the more normal lung portion of the lung. It's like somebody came up behind you and went like this and kept you from taking a deep breath. It has somewhat that same feeling. Now, what about asthma? Well, this would be like a normal airway, a normal bronchus, and this would be an asthmatic one in which there's inflammation. With inflammation, there's swelling and mucus blockage. Remember, too much mucus. And then the muscles around the airways tighten and cause airway obstruction. It's hard to move air into and out of the lungs. And another picture of that is right here, is where the muscles around the airways, you have these muscles, and they're bronchial muscles, and they tighten around the airway. And a person with asthma might have asthma triggered by something that you're allergic to, or asthma that occurs at night, or asthma when you exercise. This is kind of what happens when you have an asthma attack or an asthma flare-up. And another word for flare-up, by the way, is exacerbation. And so we in the field call it exacerbation, but we use the term flare-up and exacerbation interchangeably. I'm telling you that because there's a future slide. Okay, now, I know that there's some people here with pulmonary fibrosis. This is the scarring of lung tissue. Now here would be a normal lung, again, around the 23rd and final branching. Okay, so you now have normal appearing alveoli. And here is where the scarring develops in between those. And you have this kind of a situation. Here is normal, and here are the thickened thickened alveoli, thickened alveolar walls. Now normally the alveolar capillary membrane, the alveolar wall, is smaller than a red blood cell. A red blood cell is pretty small. So its oxygen goes very freely in between the blood vessels and the alveoli. So here would be the normal appearing lung, and this would be a lung that has the thickened alveolar wall. Okay? So it's harder to take a deeper breath, and it's hard for oxygen to get through that thickened wall. So here is the wall, and so I talked to somebody with pulmonary fibrosis. I said, this is the slide you got to look at, because this is the very thin membrane, thinner than a red blood cell, and this is a red blood cell going through, and of course this is the normal situation, and notice that the red blood cell is getting redder, right? Because it's picking up oxygen. And that's normal. But what happens if this membrane is thickened as you have scar tissue build up in pulmonary fibrosis? Well, when you have that, then it takes a while for the red blood, for the oxygen to get across the membrane. Now at rest, the oxygen can do a better job of getting across the membrane because there's plenty of time to do that. The blood flow is relatively slow. But when you exercise, then you don't have time. The blood flow goes faster, and it's difficult to get the oxygen across. So those of you who have pulmonary fibrosis, you notice that your saturation may be normal or maybe in the mid-80s at rest, but as soon as you start to move around, it goes way down and it plummets. Let me tell you something that may be very useful. I notice a lot of you have oximeters. Remember that the oximeter takes a reading when it gets that information. It takes about 30 seconds for that information to get down to your finger. So take that into account when you're looking at your oxygen saturation, and you're trying to do biofeedback to increase your oxygen saturation. I can talk about that during questions if people are interested. But so here's one of the problems. Again, pursed lip breathing, believe it or not, is associated with COPD. It actually works even better in people with pulmonary fibrosis. So listen up, okay? Now, here is a cross-section of lung. This is just below the carina, where the first splitting occurs, the right main stem bronchus, and here is the beginning of the left main stem bronchus. You can't see it really going to the left yet in this particular cut. But around the periphery here are these scar tissue. And the radiologists call it this pattern honeycombing, because it in fact does kind of look like honeycombing. And this scar tissue, it's not really accomplishing gas exchange like you really need to have happen in the lung. So, and this is a much more advanced case where you basically have no real normal lung tissue. So you're really, it's really very, very borderline in this case. Okay, so how do you manage lung disease? What you do at home makes the biggest difference. As a pulmonary rehab specialist, I tell the patients that if you don't do it at home, it doesn't get done, right? Because you might see me once a month. We have our patients come back once a month, and that's relatively frequent. But you deal with your disease day to day, hour to hour, minute to minute, sometimes second to second. So what you do makes a difference. And of course, in rehab, the engine that drives rehab is your exercise program. That has to be put down as the key to feeling better. Because the exercise program helps you deliver oxygen to the tissues and pick up carbon dioxide to get rid of the carbon dioxide. Of course, no smoking. Now, no vaping, right? You take your medications, your oxygen, as prescribed. Medications help to open up the airways. The oxygen helps you get the oxygen in. Live active and quality-filled lives. You live an active life, then you're going to be able to enjoy an active life. Exercise, the engine that drives the whole system. And you're partnering with your doctor. Your doctor can advise you, but again, even if you go to a standard physician visit and the doctor says, okay, here's a prescription, then it's all up to you. And sometimes people don't even fill the prescription. Doctor says, well, how are you doing? Well, you know, it's not working. Oh, really? When did you start your prescription? Well, I haven't filled it yet. Oh, okay. It's kind of like that segment on House. Remember the House doctor? And the patient says, my inhaler doesn't work. And the Dr. House says, well, show me how it works. So, okay? You can see that on YouTube, by the way. Okay. Now, the way we handle pulmonary rehab, we used to have a discrete pulmonary rehab program. We don't have that anymore. Because pulmonary rehab has to be a lifetime venture. And so our program involves pulmonary rehab for life. You have a disease that is chronic, it's progressive, it will get worse. You have exacerbations or flare-ups that make the disease worse. And you have to deal with all of those things and recognize when bad things are occurring so that you get help right away. And you are a part of getting that help. Okay, well, we have a set of daily rituals. When patients get up every morning, they get dressed. They don't stay in their pajamas. They don't stay in their night clothes. Take medications, oxygen. Check your oxygen saturation if you're on oxygen or you're a person who may need oxygen and you're in between whether you're taking oxygen every day or under all conditions or what. Airway clearance. Those people who have chronic bronchitis or bronchiectasis that have to clear their airways. You clear your airways, you have a better day because you're getting the secretions out of the way, the mucus out of the way. Pursed lip breathing. It's very, very effective if you do it right. So I will spend just a little bit of time on that. How am I doing? Okay? Okay. Okay, so walk daily. The walking is helpful not only as exercise and as getting your blood moving and getting your lungs moving, but it also helps identify if you're having a flare-up. So people say, you know, how do you know if you have a flare-up? Well, if you have a daily exercise program, you'll know. If you are more short of breath for the same level of exertion and your secretions have changed and maybe your oxygen level has gone down. So you check for a flare-up at the end of an exercise and then we have a rapid action plan, okay? So we see the patients monthly, we assess, we train, we reinforce what people have to do. So patient's job is to take care of themselves. Our job is to make sure the patients do their job. And so I have this key showing this. This is a key slide. This is a key membrane. Now, how do you take your inhalers? Well, it's important that you take your inhaler in such a way that it goes way down into the lungs. By the way, this didn't hurt when I did this. Okay? But think about this animation when you take your inhaler, because you're really trying to get that mist, we say particles, but that mist to take a turn at the throat and go down towards the lungs. And under the best of conditions, the efficiency of it is about 19%. A lot of the rest of it is wasted. You end up swallowing the secretions or even end up blowing it out at the end of the inhalation. So let me show you this again. So you breathe in slowly and make sure it makes that turn at the throat, and you have all of the nebulization going to the right section of the lungs. Of course, only 19% at best actually does that. Now, pursed lip breathing. Some of you who have trained in the past, a medical artist named Frank Netter, he did fabulous drawings. So if you get a chance to see his drawings, they're really terrific. Well, I've animated this one. And so this is the emphysema patient who's underweight, getting enough oxygen, but is having a lot of trouble doing it. So we call this person the pink puffer. But notice he's inhaling through the nose and exhaling through the mouth. That's key. So I'm going to play it again. So inhaling through the nose, exhaling through the mouth. Why does that work? Notice he's doing that. So why does that work? Glad you asked. Now this is a model that I built to do a study on high-flow oxygen therapy, and it's so perfect for this animation that I borrowed my own models here. So normally you're breathing in and out through your nose. Most people are breathing with your mouth closed, in and out through your nose, and that's fine. That's how we're built, right? And so you inhale and exhale, and at the end of exhalation, the air in your nose is air that was in the lungs. It's got a lot of carbon dioxide in it. And you re-inhale that air on the next breath. Okay? Again, that's normal. But that's how we're built. If we were birds, we wouldn't have that problem. They've got a circulatory breathing system. They can fly high and for long periods of time. So birds have got it right. We still have some work to do. So here's in pursed lip breathing, you inhale through the nose and exhale through the mouth so that all the air in your nose is always fresh air, not stale air. Okay? So in with the fresh, out with the stale. Smell the roses? Blow the candle. Don't blow out the candle. We tell our patients, don't blow out the candle. You get arrested. Don't blow out the candle. You just blow the candle just to make it flicker. So I tear off a piece of paper and I show them. Right? Because I don't want to buy candles. Okay? And then I tell the patient, here, this is a souvenir. This is your candle. Okay? But you get the point across. Okay? Now, each time you take a breath, let's say it's a 500 milliliter breath. That's roughly a half a liter or a half a quart. Okay? That one part of it is dead space. And that's 150 milliliters of that is dead space. So you have that overhead. Each time you take a breath, you have that overhead of dead space. But if you inhale through the nose and exhale through the mouth, you're bypassing 40 milliliters of that dead space. So if you were at a business, you were running a business, and you can cut off that amount of overhead, wow, you do very well. Okay, so that is part of why pursed lip breathing works. And then finally, if you exhale slowly, you're giving yourself time to get rid of more CO2 that is coming out of the alveoli. You all with me? Okay. Now you're all pursed lip breathing experts? Everybody. Okay, good. So now, finally, we have a flare-up. What is a flare-up? It's an exacerbation. An exacerbation or flare-up. You were right with me. How am I doing so? Is that okay? Okay, good. Thank you. Here it is. This is normal breathing. But when you have a flare-up, then you have some inflammation along the linings of the airways. And it closes down some of the airways. And then furthermore, if you have infection, then the sputum, you've got sputum lining the airways too, and blocking some of the airways. So it's harder to breathe. So when you have a flare-up or an exacerbation, that's the time that you're more likely to go to the hospital with this disease. But if you get to it right away, you can prevent all of that. You have to do that by making a deal with your doctor, having a rapid action plan, who to call, how to call, and what to do in the case of a flare-up. And I'm telling you that we can make a difference, and I'll show you the statistics on it. Now, we live in Los Angeles area, and it's bordered with forest. We have the San Gabriel forest, and we have the San Bernardino forest, and we have forest fires. And so here, let's say the forest fire starts, okay? If you catch it when it starts, then you can stomp it out, or throw a bucket of water on it, or maybe a garden hose. But after a while, then it takes more than that. It takes a fire brigade. It takes helicopters. It takes the bombers to get rid of the forest fire, and a lot of the forest is consumed. And all you had to do is to get to it right away. So it makes a big difference, right? So it turns out to be a fairly decent analogy. So our rapid action plan is to recognize more breathlessness for the same level of exertion, a change in the secretions, a drop in the oxygen level, sometimes, not always. And, you call the doctor, and I want to be called, by the way. I'm not one of those doctors that says, no, don't call me, call the emergency room and all that. You end up getting hospitalized. So we can get to it right away. We don't have to go that far. Prednisone, medication that everybody loves, right? Prednisone. Okay, but if you do it right, it's an anti-inflammatory that can save your life and certainly save hospitalizations. Antibiotics, I happen to like azithromycin, Zithromax, the Z-Pak, right? 5-day dosing of antibiotics. Again, got to get to it right away. Inhaler medications, because they open up the airways. And pursed lip breathing, again, that helps too. That helps your breathing, that helps your oxygenation, and it helps you get rid of more CO2. And then, of course, adjust your oxygen level according to your oximeter. Okay, so here it is. Here is the exacerbation or flare-up, and this is what we wanted to do. We wanted to clear up right away. And the only way to do that is to get to it right away. If you wait and say, well, I don't know if this is really going to be bad, I'll just wait and see if it's bad. Well, there's destruction that occurs along the linings of your airways and in your lungs, and perhaps pneumonia. So you don't want to wait. Thank you. Okay, so in exacerbation management, you recognize it really fast, treat it intensely, no delay, monitor closely, treat until it's fully resolved. That doesn't always happen, as you know. And then anticipate the next. Why anticipate the next? Because if you have one flare-up, you're more likely to have another flare-up. Exercise, regular exercise, okay? And again, remember that this whole system is helped by your exercise program, by exercise, okay? By keeping active. Now, there was a project called the Dallas Project, where they took guys in their mid-20s who were healthy people, and they put them to bed for 3 weeks. And their ability to exercise after that 3 weeks was abysmal. It was really terrible. These are young, healthy people. In fact, a number of them were recruits, Air Force recruits. I'm not sure about that. But they tested them after 30 years, and after 30 years, they did better, most of them did better than they did at their low point when they were in their 20s. I'm really saying being active, exercise is important. And exercise is also good for mortality. So the more you exercise, the longer you're likely to live, on a statistical basis, of course. So, the benefits of exercise is you feel better, you're less short of breath, less anxious and depressed, because exercise is good for depression. Self-efficacy, your ability to manage yourself, your disease. Longevity, quality of life, and 30 minutes of activity on most days of the week really is enough to make a big difference. So you're basically getting a physiological fix, sometimes even stimulating endorphins. These are your body opiate compounds. So if you have to watch this one, Roxland Cole, you got to see this one, okay? This was the natural course of the disease, and you end up hospitalizations or more hospitalizations than emergency room visits. And this is when you have, and when you live active lives, and that makes a big difference. So I took this off the internet. Yes. Okay, so our outcomes, most of the time, exacerbations, 27% of the time, actually lead to hospitalizations. In our group, it's 4%. Got it. So you can enjoy life with COPD. You should live, you should love, you should have humor, you should participate, be active, help others, do problem solving, in fact, get together and make life work for you, your family, and your friends. And with that, I'll say thank you. Is there time for questions?
We always talk about obstructive. What about restrictive? Does it fit in all this stuff too? 'Cause I have both.
Yes. The question is, we talk about obstructive, but what about restrictive? Actually, when I was talking about pulmonary fibrosis, I was describing restrictive. I didn't go into a lot of detail on it, but yes, but you're limited as to the volume of air you can take, and obstructive is to how rapidly you can move the air. Great question.
Seems like I shouldn't be breathing at all.
A lot
I
of
can't
the,
get it in, I can't get it out.
that's right, but everything is a matter of degree, right? So you have a set of predicted values for person, your age, your height, and your gender. And you can be some percentage of that on both the obstructive and restrictive. Okay.
You mentioned downside on oxygen. I like to exercise, and I try and keep my saturation at 90, but I don't titrate, I think is the word you use, enough probably. I get lazy, and so I can sit around at 94 and 96 because I have the oxygen 24/7. Am I hurting myself, or should I titrate the best I can to keep it right at 90?
What you should avoid doing, and I have actually written an article that is a part of Up to Date for physicians, and we say if you enrich your oxygen, not just what you naturally do, but enrich your oxygen, there's no benefit above 92%, and above 96% there may be some disadvantage. That disadvantage occurs over a long period of time. Okay, it's not right away. So if all of a sudden you get a whiff of oxygen, don't worry about it.
Yes. On my last scan, I have the fibrosis, but they said there was evidence of calcification. What does this mean?
Okay. The question was whether on his CT scan, probably lung cancer screening, CT scan, they showed calcification. One of the things they look for, aside from whether there's a nodule indicating the possibility of cancer, or COPD, which is the emphysema changes that you can actually see, which I kind of showed you. But they also they also look at the blood vessels. And if there's calcification along the linings of the blood vessel, that may indicate some cardiac disease. Now, it's normal at, well, I won't say normal, but it's usual as you get older that calcific deposits occur along the linings. So they've got a grading system that tells you whether you should worry about it or not. But again, your pulmonary rehab program, your exercise program is very helpful in dealing with that situation. Thank you. Other questions?
I have a question about action plans. How do you feel about patients having on hand prednisone, antibiotics, diuretic titration?
Okay, well, having the medications for an action plan is essential because you can't get to it right away, and everything is very time sensitive. So I'm a very strong believer in the action plan. Of course, it makes a big difference in our population, but it also, you've got to have medication ready to go in the medicine cabinet. So I prescribe a medication, I tell the patient, this medication is not for you, it's for your medicine cabinet. But when you have a flare-up, or you have signs of a flare-up, go to the medicine cabinet, grab that medication, and call me right away. Now, am I on the other end of the line? No, but they know what to do, they get started, and when I call maybe 3 hours later, they can also tell me whether maybe I'm getting some early benefit from that medication. In other words, everything is very time sensitive. Sometimes it's even that time sensitive. Other questions? Yes, Bob.
In terms of the participation of the patient in medications, I just wanted to mention in our Breathe Strong guide page about the ABC, then work with the patient, with their doctor and the respiratory therapist. And could you comment on that?
Yeah, first, may I say, it's an excellent guide. I was taking a look at it last night, and just marvelous. It takes into account not only what what you recommend, but why you recommend it, and that's extremely important. Your question was.
Doctor and respiratory therapist for the medication and devices.
Okay. What I recommend is that the patient goes to their doctor and said, look, I got this lecture by a doctor who is very action-oriented and has a rapid action plan, and it's made a difference in his population. Can I have such a plan? And if I do have such a plan, then can I have the steroids, the antibiotics, and the inhalers on hand, all ready to go? And should I have an oximeter? Okay, so yes, patients do go to their doctor, and after I've given talks, they've gone to their doctors, and the doctor would call me up. What did you tell my patient? And I tell that doctor and say, you disagree? Well, there's some patients, they abuse their medication. Well, part of our job is to teach the patient how to take the medication, why to take the medication, and the possibility of abuse. And don't start the rapid action plan and not call. You've got to call. That's a part of it. Okay? Because one prescription doesn't meet everybody's needs, basically.
Where would I find information on the different stages of COPD?
Information on different stages of COPD. There are a lot of websites, but the COPD Coalition, that would be a good one. The GOLD guidelines, GOLD, Global Initiative on Lung Disease, that would be another one. Some of the American Thoracic Society and the American College of Chest Physicians also have one. I would stick to well-known websites like Mayo Clinic and Cleveland Clinic, or somebody local that you know of, for advice.
Is there a good alternative medication that has the same benefits as prednisone that can be taken without the risk of anabolic steroid psychosis?
Okay, good question. I'd love to be able to come up with a real good answer. Prednisone is really the best of the medications for that kind of thing. But I hasten to say that there should be a strategy involved. Shouldn't put you on prednisone from now on. No, prednisone is something you start when you have the very first sign of a flare-up. And if you hadn't been on prednisone for a while, and your flare-up clears up, say, in 5 days, or 5 to, let's say, 8 days, you can actually stop the prednisone suddenly. So you have all the advantages and very few of the disadvantages of the prednisone.
So can you take it
It's on a PRN basis if you coordinate that with your doctor, okay, and under the circumstances that I was just describing.
I'm sorry, I have bronchiectasis, and I am also an alpha-1 carrier, I was told. Do people with alpha-1 or are alpha-1 carrier have more of a propensity for getting bronchiectasis or lung diseases?
Okay, well, if you're alpha-1 carrier, and she was talking about alpha-1, and I think probably some of you have known, in fact, we have an exhibitor here, have the alpha-1 testing kits. If you have the full disease, then you might be a candidate for the alpha-1 replacement. And it seems that it does make a difference. Let's say if you're a heterozygote, which means that you don't have the full disease, but let's say you have, let's say, a portion of the disease. Kind of inaccurate way of describing it, but genetically you don't have 100%, you have some percentage of it. You probably won't get the replacement therapy, nor will you probably benefit from it. But it really depends on what which gene that you have.
Well, will the bronchiectasis ever be able to be cured?
Oh, okay. I didn't hear the bronchiectasis.
Bronchiectasis is what I have now.
Say again.
Do you get rid of that?
Oh, that I'm not absolutely sure about that. I have to just say I don't honestly know. You have more of a tendency towards having a lung disease. Bronchiectasis is sometimes, maybe even often, described as one of the chronic obstructive pulmonary diseases. But it also depends on why you have bronchiectasis. I work at a cancer hospital. We do bone marrow transplants. And people who have bone marrow transplants, sometimes they get a disease called graft versus host. And one of the problems from graft versus host, where the graft itself starts attacking the rest of the body, and it's a bad thing to have, but one of the problems is bronchiectasis. And from that, it probably is not related at all to alpha-1.
Okay.
Okay?
Thank you.
Uno más? Yeah. Who's going to get there first? Okay.
I think the other part of that question, and I'm wondering about the answer to it, is can you get over bronchiectasis? I know that in that instance where you said when you have the transplant, but if you don't have that, if there's another reason why you have bronchiectasis, is it there forever or can you get rid of it?
Okay, the question is, do you ever get rid of bronchiectasis? And the answer is that probably not. But when you have bronchiectasis, then the way you feel the bronchiectasis is that you have more airway obstruction, you have recurrent respiratory infections. You can prevent a lot of the consequences of bronchiectasis by, again, being very active, mobilizing your secretions. And if you're a person with bronchiectasis with a lot of secretions, some people don't have secretions with bronchiectasis, by the way, but if you have a lot of secretions and there's a big infectious component, then you have to get on the infection right away. And again, a rapid action plan is very, very important, very useful. There is, and there are medications like your Advair, or I guess I can use brand names, right? Okay, Advair, Symbicort, Dulera, Brio, any one of those could be helpful in bronchiectasis. So it's a disease, you have the disease, and it's an outpocketing of the bronchial passages, but sometimes that outpocketing, their secretions, they get in there, you get infected, and you're dealing with that. If you live very active lifestyle, if you mobilize your airways, and you use bronchodilators as optimally, you can actually prevent some of the complications, or at least reduce some of the complications. I hope that's a better answer for you. Okay.
Okay, thank you. Thank you so
Thank
very
you,
much,
everybody.
Dr. Type.
Thank you.
So you may encounter defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are, what you can rise from, and how far you can succeed. So now I want everybody in this room to sit up straight in your chair and pull those shoulders back. Enough of that slouchy thing. Pull them back. Take a few nice deep breaths. Feel that belly move. And know that you're getting a little bit of oxygen down in your lungs. Because we've been sitting here for an hour like this, right? So think about that every once in a while throughout your day. Get those shoulders back, okay? One more little comment before you take a break. When you change the way you look at things, the things you look at change.